depending on where you're calling in from. My name is Jillian Bartlett Escalante. I'm the Executive Director of the Network Coordinating Office of the Primary and Integrated Healthcare Innovations Network, which I will be referring to by the delightful acronym of PIHCI for this learning series. And we're very pleased to host today in collaboration with BRIC Nova Scotia, so that is the PIHCI network in Nova Scotia, a learning series. And I'm going to go over a few things before I introduce the series and our speakers today. I'm going to go over a few things about how a webinar works, do a land acknowledgement, and then move into our speakers. So today we will be talking about implementing case management in primary care, and our speakers will be sharing findings and reflections from a multi-province strategy for patient-oriented research study. Our network is supported by the Canadian Institutes of Health Research under the Strategy for Patient-Oriented Research funding envelope, along with all of our partners, because we do work with matched funds. So a few things about being on a webinar. You will notice that you have two options. You can actually ask questions, but what we prefer to do is if you have a comment you wish to share with everybody, you'll notice in the chat you have the option to either just share it with the panelists or with everyone. So if you're having technical issues, please just share with the panelists, and myself or Jamie will pick up on that. If you have a comment you just want everybody to read, put everyone. If you have a specific question, there is a box at the bottom that is Q&A. If you click on that, you can write a question there, and I will be reading those aloud during the Q&A session. And you can make that, you can put your name or you can make them anonymous, whatever you prefer. If you put your name, I will be acknowledging your name. Si jamais vous avez une question en français, vas-y avec ça, je vais faire la traduction pour toutes les autres personnes. So please be, if you feel more comfortable writing a question in French, I will read it in French and do my translation of it, which will be fairly accurate. So don't be shy to ask a question in whichever language you would like. So before we get started, I am going to read a virtual land acknowledgement of traditional land. And this was developed by the Canadian College of Family Physicians Indigenous Health Working Group. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. We recognize that the many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. We respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all attendees to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging new culturally safe relationships, and contributing to reconciliation. Okay, so if ever you're having connection issues, I encourage you to close your video, and hopefully that helps. I do know Zoom has been a bit buggy, and depending on whether Wi-Fi works or doesn't work. So now I am going to turn over this session to Alana Delahunty-Pike. I hope I got the middle part of that right, Alana. And she is going to also go ahead with some introductions and kick off our speakers. Thank you.
Okay, can everybody see that?
You're good.
Okay, perfect. Thank you. Thanks very much, Jillian, for that introduction. And thank you for having us. We're very excited to be presenting today. So I'd like to acknowledge that the lands on which we are hosting this meeting are the lands and territories of many nations. And I'd like to acknowledge that from where I am here in Nova Scotia, we are in Mi'kma'ki, the traditional or ancestral territory of the Mi'kmaq people. And we are all treaty people, and our relationship is based on peace and friendship. So today I am one of the members of the PIHCI team, and we will be presenting, as Jillian mentioned, on implementing case management in primary care. So these are some findings and reflections from our multi-province SPOR study. So just to start off the introductions, as I'm first on the list, Elena Delahunty-Pike is my name, and I am a research associate at Dalhousie Family Medicine in the primary care research unit. So that's at Dalhousie in Halifax, Nova Scotia. And I'm also the coordinator for the Nova Scotia portion of the study. And I'll just let the next presenter, Catherine, introduce, and then we can move down the list.
Yeah, so hello, I'm Catherine Hudon, professor at the Family Medicine and Emergency Department, Emergency Medicine Department of University Sherbrooke, and I'm the principal investigator of this study.
Hi there, my name is Dana House. I'm a research associate and I'm at the Primary Healthcare Research Unit at Moral University. And I'm the research coordinator for the Newfoundland and Labrador team with PIHCI.
Hi, everyone. I'm going to keep my camera off because I am having internet problems. So my name's Donna Rubenstein. I'm a patient partner calling in from Nova Scotia. When I first heard about this project, I joined because of what it was about. It was a big leap for me because I had no research experience, but I was a patient who had faced a lot of challenges accessing support for my health situation, and the case management model was incredibly exciting. So I thought it was possibly a game changer in how things were done, and I wanted to contribute to helping move that forward. And the last person is Linda, who unfortunately, one of the other patient partners took ill today, so she won't be joining us. So I get to speak for both of us.
Thanks, Donna. Okay, so we have many different partners that are involved in this multi-province study. And of course, our different funders. And specifically, I'd like to mention the Canadian Institutes of Health Research. And this is a SPOR PIHCI Network programmatic grant. And then also acknowledging PIHCI, the umbrella of primary care focused research networks across Canada, who's co-organizing this event with BRIC Nova Scotia, so our provincial research network. And I just wanted to chat a little bit about some of the support that BRIC Nova Scotia offered us in both the pre-funding and post-funding phases of this project. So that pre-funding support that they helped out with was putting a multidisciplinary team together. And they also helped find some match funding as well. And then once we received funding, they helped with hiring a research project coordinator. They also helped with identifying patient partners here in Nova Scotia. And they helped identify clinics where we would be conducting the research along with some of our health system partners. So our aims then for this presentation today, we're going to be talking about the PIHCI study, and we'll also be talking about case management within that PIHCI study. We'll highlight our implementation study methods, then some of our implementation findings. We'll talk about some patient partner reflections. So Donna's going to chat a bit about that. And then we'll close out with some more global reflections. And our overarching aim that we're hoping to achieve today is, as a SPOR programmatic phase 1 grant, we're hoping that our experiences and reflections in relation to this implementation phase of our study can help guide and inform future phases of these grants. Alrighty, so the goal of our study that we're chatting about today is to study the implementation process of a case management intervention. So that's nurse-led for individuals with chronic diseases and complex care needs in primary care clinics across Canada. And sometimes these individuals can be frequent users of the health system. So as you can see on the map there, our 5 provinces are New Brunswick, Newfoundland and Labrador, Nova Scotia, Quebec, and Saskatchewan. And we have typically 1 to 2 clinics per province and 1 to 2 patient partners per province. And the PIHCI study is a bilingual, multi-provincial, multi-jurisdictional project. And for the purposes of this presentation today, we'll be focusing on implementation findings from Quebec, Newfoundland and Labrador, Nova Scotia, and New Brunswick. The Saskatchewan Sturgeon Lake First Nation Clinic has a more community-based research process with a bit of a different timeline. So this gives a really nice depiction of what nurse-led case management is all about in this study. So it starts in the primary care clinic, which is often a collaborative family practice or a health team with a registered nurse or a family practice nurse taking on that nurse case manager role. And then there are different providers such as family docs or nurse practitioners, and they're working with the patient then for this case management intervention. And then there's other health resources. So top right there, that circle, other health resources can represent different specialists, allied health professionals, dietitians, different wellness programs that the patient could be referred to. And then bottom right, we have the hospitals, so inpatient and outpatient services. Then bottom left, we have community resources. And this bus really is there to represent, any kind of transportation supports that a patient might be offered. Of course, there's many other community resources depending on the province, the jurisdiction. There might be some housing supports and various other community programs. And then top left represents family and social support that the patient may be able to access. So family or caregivers that might be involved in their care and any kind of social network. So we have the various case management steps here. And it obviously starts with a very patient-centered approach. Then there's an identification of the patients that may have chronic diseases and complex healthcare needs. So that identification happens in the primary care clinic, and it might happen by different providers letting the nurse case manager know about some patients that case management might work well for, and they might benefit from. So then once that patient is identified, there's an assessment of the patient's needs and preferences, and that happens between the nurse case manager and the patient. And then there's a development and maintenance of an individualized services plan, or ISP. So the ISP is an organized written plan of services with details on the needs, goals, support. So those community supports that we mentioned in the previous slide, different social supports, any activities and resources that might be required for the individual. And it's really created through conversation and collaboration between the patient and nurse case manager. And then it typically culminates in a meeting with the patient, the nurse case manager, the primary care provider, so family doc or nurse practitioner at their clinic, and then sometimes other service providers, so specialists or other allied health professionals that might be invited to attend or to contribute somehow in that meeting and that individualized services plan. So then after that, there's a real coordination or aim of coordination of services among health and social service partners. And then, the ultimate goal really is the provision of education and self-management support for patients and their caregivers or families, if they have people involved in their care. So our study phases, so we'll be presenting findings of the completed phase 1, that implementation of case management. So just that red arrow there. And then we're currently in phase 2, which is the realist evaluation of case management. And we will have findings of that, so the impact of a case management intervention in about a year. And then phase 3 at the bottom there would be the scalability of case management, and that'll be a little farther down the road. So it is worth noting that phase 1 was modified due to COVID-19. The initial plan for phase 1 was to implement the full case management intervention, or CMI, with 30 patients in each participating clinic across the provinces. And so we all be working with a nurse case manager. The patients would be working with a nurse case manager for a full year, so that we as a research team could examine the facilitators, barriers, and contextual features of implementing a case management intervention. However, this phase, was cut significantly short with COVID-19. Each clinic, though, did manage to conduct the planned focus groups and interviews with clinic staff and healthcare providers by early 2020, so just before COVID-19 started in March 2020. And then, of course, it really forced us to pause any kind of further recruitment and data collection. And so after some lengthy delays, we had to shorten this phase 1 and abandon plans to engage patients in a year-long intervention. So our implementation analysis is based on those, initial interviews and focus groups, and reflections from clinic staff, and you really get the provider perspective in the implementation findings. Nevertheless, though, we did collect some rich and nuanced data from multiple contexts that sheds light on the concerns and challenges associated with implementing case management. And so we did this work as a multi-province research team, and we collaborated across Eastern Canada, so all the way from Quebec through New Brunswick, Nova Scotia, and Newfoundland and Labrador. And we were working in English and French and adapting to different timelines and ways of doing things in these different provinces. And the implementation steps, so bring case management into a primary care clinic. This shows different steps. They don't always happen in a linear fashion, but typically once that nurse case manager has been identified, there is a case management training that is a 3-hour case management module that they're able to sort of watch and consume at their leisure. And then there may be a research orientation. So that would be between the nurse case manager and somebody on the research team in whatever province they're in. And, going through that informed consent process, which is key at the beginning. And then any data collection that might happen, like questionnaires or interviews. And there's also peer support. So nurse case manager to nurse case manager peer support. And then as well as a case management expert that we have on our team. And through this, there's lots of opportunities for patient partner support embedded throughout these processes. So, patient partners coming and chatting with the nurse case manager or different people at the clinic around some recruitment strategies, any kind of patient-facing materials, things like that. So I'll pass the next slide over to Dana.
Great, thanks, Elena. So I'm just going to walk us through some of the specifics of the implementation study. So we conducted a qualitative multiple case study using a participatory approach to provide an in-depth description of the facilitators and barriers of the case management intervention that Elena just described. And as Elena mentioned as well, the study was guided by principles of the Canadian Strategy for Patient-Oriented Research. So it involved the engagement of patient partners through various aspects of the research. Also, decision makers and clinicians collaborated with the research team at different levels according to their availability and expertise. Our data collection and analysis relied on a conceptual framework for the implementation analysis of a case management intervention. You can see that depicted in the circle here on the right side of your screen. And this framework was developed by our colleague, Alia Danish, and other members of our research team. And it was inspired by elements of 2 other multi-level frameworks, which you'll see depicted in these 2 circles to the left of your screen. So just in brief, the consolidated framework for implementation research proposed by Dan Schroeder and company offers a conceptual structure for understanding and evaluating implementation according to 5 major domains, 3 of which relate to contexts at different levels. A 4th domain is the characteristics of the intervention. And finally, the 5th domain is the implementation process itself. The second conceptual framework that was informed, the one that we employed, was the Rainbow Model for Integrated Care by Valentine and Company. And that one really describes the central role of primary care in integrating the multiple levels of healthcare. And those levels might include, system integration at the highest or macro level, organizational and professional integration at the intermediate or meso level, and clinical integration at the more local or micro level. And the Valentine framework enables analysis of the causal relationships within and between those various integration levels. And those relationships may interact depending on the specific context of the healthcare delivery. So on the whole then, the Danish framework enables us to understand the core components of the case management intervention as influenced by the context of the implementation at micro, meso, and macro levels, and to identify the related outcomes for patients, healthcare teams, and the healthcare system more widely. Next slide, please, Elena. So in regards to methods, semi-structured interviews and focus groups were conducted by a research coordinator in each of the 4 participating provinces between January 2019 and January 2020. The interview guide for those interviews and focus groups was developed based on that conceptual framework I just described to elicit information related to each of the implementation analysis elements. So those include the planning, engaging, and executing phases of the implementation, as well as contextual elements that influenced it. We conducted all of the interviews and focus groups either over the phone or in person at the clinic where possible. They all took about 45 to 60 minutes. They were audio recorded and transcribed verbatim. And in addition to these interviews and focus groups, the research coordinators in each of the provinces kept field notes during that same 12-month period. And those included reflections about meetings with clinic staff and patient partners, research activities, as well as some observations about the challenges of implementing case management intervention. Next, please. So in terms of our study sample, we recruited 6 primary care clinics in the 4 participating provinces using a purposeful sampling strategy. And each intervention that was implemented in the clinic was considered a case. The lead researcher's knowledge and experience with the health network in each province really helped us to identify and recruit these clinics. And the inclusion criteria for recruiting clinics included that no case management intervention had been implemented previously, that there was a strong interest and engagement on the part of the clinic manager as well as the clinical team. And it was also important that there was an available and interested primary care nurse who could act as the nurse case manager to really lead the case management intervention. The key informants who we interviewed, who participated in the interviews and focus groups, were again recruited through purposeful sampling. And we essentially contacted them by telephone or email to set up those interviews and focus groups. The next, please. So in terms of a breakdown then, we conducted individual interviews with 10 nurse case managers, 5 health service managers or clinic managers, and 4 family physicians or other healthcare providers. We also conducted 6 focus groups, and those involved a total of 20 family physicians and 8 other healthcare providers. Next, please. And during those interviews and focus groups, we asked the participants to complete a short demographic survey so that we could characterize our sample. And so our sample then was comprised of 42 women and 6 men. The participants ranged in age from 25 to 74 years old. In terms of years of professional experience, the range in our sample was 1 to 42 years with a mean of 13 years. And finally, in terms of the number of years working in the specific clinic, those years range from 1 to 32 with an average of 8. Next, please. So for our data analysis, we performed a participatory mixed thematic analysis. Again, that was based on the conceptual framework that I described a moment ago, as well as on emerging themes that we saw coming through. So as a first step, we developed a code book, the coordinators and assistants on the team, and that was based on the categories in the conceptual framework, which included planning, engaging, and executing phases of the implementation, as well as contextual influences. The research team met several times to sort of validate this code book by first coding the first few transcripts that were completed. And then once a coding scheme was finalized, the rest of the transcripts were coded. And all qualitative data, including the field notes, were integrated and analyzed using NVivo, a qualitative data management software program. So emerging themes, which included facilitators and barriers to case management intervention, were synthesized and discussed first during provincial team meetings that involved the lead researchers in each province, as well as the research coordinators and assistants and the patient partners. And those meetings were meant to really identify the more salient characteristics of the case management intervention within each clinic. The themes were then incorporated into a larger cross-case table that reflected the data coming out of all of the clinics and were reviewed and discussed by the full study team. To, for example, identify patterns and contrasts and discuss again these emerging themes. The table content was revised following an iterative back and forth process until consensus was reached and validated by all the research team members. And so in keeping with the participatory approach, all team members, including patient partners, participated in key steps of the analysis to ensure meaningful interpretation and reliability. Patient partners brought their unique perspective on the data, highlighting elements that were most salient to them or which they expected to see in the data, but which did not emerge. They expressed disappointment that patients were not interviewed as part of the implementation phase, which, as Alana explained already, was an unfortunate consequence of the severe delays caused by COVID-19. Next, please. So next, then, I'll just walk you through some of the key findings that came out of our implementation analysis. And they've been organized essentially in terms of the key facilitators and barriers that were reported by the providers that we interviewed in interviews and focus groups, the physicians, clinic managers, and nurse case managers. And generally speaking, we didn't find as many differences as we might have expected, especially in light of the multi-provincial, multi-jurisdictional nature of our study. Many of the facilitators and barriers were similar across clinics, and that's what I'm going to present here. So we found that having a good communication plan from the outset and solid provider engagement in the clinic was found to be a key element to successful case management implementation. Strong managerial leadership, engagement, and support from both the clinic managers and providers were critical to implementation planning, and engagement of the nurse case manager. And related to that, we found that having a trained, skilled, and experienced nurse in the clinic who could act as the nurse case manager was critical to the implementation of case management. And finally, ongoing capacity development through team meetings, debriefs, and a community of practice for nurse case managers where they could share learnings or discuss challenges was critically important to a positive implementation. Next. And in terms of barriers, a fairly common widespread barrier or concern that was expressed had to do with the time commitment that the providers perceived would be required, as well as the related increased workload associated with implementing a case management intervention in their clinic. And some providers also questioned the need of the case management program and whether that would take away from the health services that they were already providing in their role. We heard from many providers as well that there's a lack of or varying access to medical records and charts, as well as a limited ability to share patient medical information across providers, which was found to be a barrier to more integrated care. Challenges associated with patient recruitment were mentioned as well as a possible barrier. There were concerns around the time and resources that it would take to identify those eligible patients with complex needs and multiple chronic conditions, as well as time and resources to enroll them in the intervention. Participants also expressed concern around challenges they anticipated with planning and organizing the collaborative care. So, for example, they questioned the feasibility of holding that individualized services plan meeting that was meant to really include a number of different providers, the nurse case manager, the family physician, as well as other allied providers in a single meeting. So there were concerns around the possibility of doing that given limited availability and busy schedules and so on. Finally, the participants anticipated some challenges around patients in terms of their motivation, their access to care, and their own health literacy. So I'll pass it on now to Donna.
Thanks, Dana. I'm going to try. I think I'm stable now. So looking at the barriers and facilitators to implementation, we did discover over the course of time that patient partners can actually play an important role in bridging some of the gaps and equally important, strengthen some of the possibilities for success. So what does that look like in practical terms? So patient partners can assist beginning at early on with the first stage of recruiting patient participants, kind of getting them in the door through onboarding, and then very importantly, relationship building. So the common theme is that patient partners can support both the case managers and the clinics connecting and engaging with patients. So this means things like, I think Alana mentioned earlier, ensuring patient-facing materials like recruiting posters, information packages, making sure they're user-friendly, which kind of means translating research lingo into language and formats that patients can easily relate to. And all that helps ensure a better informed and engaged participant. Another example is mock patient interviews, fine-tuning the language and the messaging, again, to better connect with patients, enhance their experience, and ultimately, from a research perspective, improve the richness and the quality of information generated. So this is also especially important when the interview information is used to develop the patient health plans, called here the ISP. I like to call it the patient health plans, the individual service plans. Next slide. Next. So here you see an example. This is what we call our patient journey map. And this illustrates a really useful recruiting tool that was created by the patient partners. So the idea is it's a way to explain to the potential patients, participants, what steps they're going to go through, who's involved, and most important, what does the program offer them? Like, why should they join? Our goal was to have the patient walk away better understanding what they're getting involved with, and at the end of the day, be able to go home and easily share it with a family member. So developing this tool was also a learning process for our team. We, the patient partners, began with the first page you see here, outlining the journey. And then when the researchers reviewed it, they came up with another idea of adding a backside, a page 2, showing a research checklist of dates the patients could keep track of, plus a note section. So that's a really good illustration of collaborating to generate a better solution. and I'll turn it over to Catherine for some final reflections.
Thank you, Donna. So obviously, this study allowed us a lot of learnings at different aspects. First, about organizing this kind of multi-provincial team study. So, and I think that we have to say that the PIHCI network was very useful to help us to just starting and just developing our multi-provincial team. So it's a very good example of what our network could help. And we learned a lot of things about just organizing this kind of big study. It implies ethics approval in 5 provinces. It implies writing a data transfer agreement among all provinces, and it implies a lot of administrative stuff even before being able to start the study. So this was a very interesting experience for us to do that. We talked about building relationship among the teams. So, and I think that we had a couple of other examples with the patient partners that building this kind of relationship, we have to take time to do this. We have to create opportunities to exchange, to talk to, and we mostly have to consider that it's completely normal to have some different perspective on the team. And we realize that taking time to discuss of these perspectives and trying to find consensus helped us to go further in our project. So, and it's the same kind of developing relationship with other kind of stakeholders as well. So, and we could talk more and more about all of the learnings and experience we got with these studies. We will be very pleased to share more learnings with the network, especially before starting phase 2 of PIHCI with other starter projects. But for today, we will end now and just let you the opportunity to ask us some questions. Thank you very much.
Thank you, and thanks for that great presentation. I'm going to ask whoever's sharing their screen to stop and to have our speakers come back on so we can see them. I have, there are no, let me just double check that I'm correct. Okay, there is a question, but I'm going to answer the questions in the Q&A first, and then I will go, there is one that has been put in the chat. Okay, so Gail from Manitoba is asking, I'm noting reference to coordination of health and social service partners. How is this partnership established for the project? And I am going to leave it up to the speakers who decide who's the best person to answer that. Otherwise, I start picking on people.
Okay, so maybe I could jump there.
Go ahead, Catherine.
Yeah, okay. So coordination of health and social services with the partners. This partnership was established in each clinic. So this was really the responsibility of each clinic to identify the most relevant partners who should be involved in the individualized service plan. So yes, so this partnership, sometimes these partners were already involved in the care services for this particular person. Sometimes these partners were not already involved, but the case manager or the patient or other people around the individualist service plan considered that it would be useful for this particular patient to benefit from this partnership. So yes, and how this partnership was developed, it depends a lot of the clinic, of the case managers, of the partners. So and this was not, we had in the training and in the tools we developed for this intervention, we have what we call our care standard. And the care standard is planned to keep enough flexibility for all of these professionals to develop their ways of doing. So I don't know, Gail, if I answered your question, but if not, feel free to ask another question in the chat, no problem.
Yeah, so Gail, if that did not answer your question, just pop another question there.
Yeah.
So the next few questions are all seem to be around the nurse and the role of the nurse. So I'm going to start with one that Allison Soprovich has asked, saying, can you please discuss the rationale for choosing a registered nurse to provide the case management role? And if you considered or would consider other healthcare team members for this role, like a social worker or pharmacist, etc.
Yeah, it's a very good question. And this intervention is planned to be provided by different kind of professionals. So yeah, it could be a social worker, or it could be other kind of professionals. The reason, and again, in the care standard is not necessarily professional oriented, it's more process oriented. So the reason why in this study it was nurses was because in most of the clinic, there were nurses were already there, but not necessarily other kind of professionals. And here in Quebec, we had a couple of clinic with different kind of providers in the clinic, but the clinic, so we let the clinic, we let the clinic decide which kind of providers they wanted to play this role. But finally, they decided that it would be the nurse because they considered that this person was the person most available to play this role. So. Okay,
so another question there, and Allison, if you have further things you want, please don't be shy to add another question in. Another question, again from Gail. Obviously, Manitoba is super interested in this. I may have missed this, but what were the funding models of included clinics? I'm a bit perplexed by the barriers regarding time and workload. Is this approach to patient care not remunerated? And this is always the issue, right? How do we get, we know what great care looks like. How do we get it funded with provincial bodies that don't always understand what great care looks like? So
yeah. Yeah, it's a very good question again. So at this stage, obviously, we did not have extra funding to pay or to add resources in the clinics. So what we asked to the clinics was to just probably changing a little bit their way of doing. A lot of in this project and in other project on the same topic, a lot of nurse case managers or a lot of nurses told us that they already did some kind of coordination in the clinic, but without standard care, or it was often pretty more improvised. Or so yeah, in this project it was trying to do different, to do better. So it's a reason why we had to convince the managers and the clinics that it was a good way of doing. But here in Quebec, we are in conversation with the Quebec Health Ministry and they are very interested in this kind of model, and they could eventually think about funding this kind of model. So again, it's finding the right balance between having a good resource utilization with the best model as possible, and sometimes, if possible, adding it, when it's possible, to add funds for this kind of models, or it's obviously it's always welcome. So, but usually at the beginning of the projects, the managers, the nurse case managers, the providers are a bit, oh, but it will take more time, it will quick. But when it is more mature, usually they realize that it's a more effective way of doing things. So.
Great, thank you. I think that's always the challenge, right? And sometimes it might be one of those things that if you have staff that are paid a salary versus by the act, it might be easier to incorporate and accommodate. Okay, I am actually answering the questions in timestamp order. So I'm next going to go to one that was left in the chat. And it said, during the study, what was a patient caseload for each nurse case manager? How many patients did one nurse case manager work with in total per month? And I realize that might have varied, but do you have an idea of average and range across the clinics?
Yeah, so for this phase of the study, it's pretty hard to say because of the COVID, as we explained. But in the next phase and in this same kind of projects or intervention that we are doing in other studies, I could say that obviously it depends on the availability of the case manager nurse. But usually we talked between maybe 15 and 30 patients, a caseload of 15 to 30 patients. And this caseload is planned to be for usually for a year. So it's not necessarily so the case manager is able to distribute this caseload to fit with his the agenda. Yeah, so but more than 30 patients, it would need more resources. So, and we did not mention that, but in some clinics there were more than only one case manager, and here in Quebec we had 4 case managers for the same clinic, so it allowed more a greater caseload, obviously. So then Dana, you have something?
Yeah, I would just add that we took care to pace enrollment. So in a way that the nurse case manager could manage, essentially, especially starting out and getting comfortable in the role. So we kept a really close eye on that and introduced just a few patients early on. And because it's on the front end, that's really time intensive around those initial assessment appointments and that individualized services plan appointment and so on. So yeah, it worked really nicely. In fact, kind of just naturally that, you know, they might have gotten a couple of patients a week and then they could kind of manage that.
Okay, thank you. I did want to note for Maureen, she's asked if this recording session will be shared. Yes, it will. Jamie, do you mind putting in the chat to everyone the link to our website where these recordings can be found? We did a whole series and there's some really great information there. We're always keen to share what our different researchers are doing across the network, because the idea is that people learn and pick these up and hopefully can scale them for their own settings. So Jamie will pop in a link to the web page there. And you should be able to find the recordings there. We are not instantaneous with the posting. And we also tend to send out surveys, although we're down from our administrator. So Jamie Demore, who's on the line, is the person that's been helping to organize all of this. And usually we send out a survey. So we'll see if we can get that done as well. So we have another question from Allison Soprovich, who is said that I really like the idea of using patient journey map to assist with recruitment. Can you please add some more details about its development and process? Was there any feedback about the success of it regarding recruitment? That is a fascinating.
I want to say thank you, Allison. You made my day to have somebody interested in that. I mean, we're very excited about it. Not just, I think it does have potential for other projects. So I'll try and be really brief because I know that everybody knows I'm very excited about this piece, but it really started, I'll say the development was a couple of us were patient partners. We're trying to put ourselves in the shoes of somebody being approached. And I'll be honest, we had all the research protocols and the documents, and we had flow charts, and I actually am comfortable looking at flow charts, but it was just, it all is, most of the research documents are developed from a researcher perspective and a system perspective. So we ended up through that saying, we're going to create our own thing. And it was really, it was really helpful. We went back and forth till we got a sense of what are the key pieces. And the question we were asking in really simple terms, it's not to replace all the other supporting documents and conversations, but when somebody does go home and their husband says, so what is this about? They don't just look blank and hand them this 10-page document and don't know. Because in the end, I mean, it's about being informed, but also engaged. And we want them to feel like they're a part of it. It's a way of beginning a journey, being prepared and, going on a road trip and having all the right things. So it was an iteration and conversations. And then, as I mentioned, initially it was, with discussions with the researchers. And then when we had something that had some substance, the researchers suggested the second part, which, so it was kind of like a piece you could put on the fridge, we said, something somebody could tack up and keep it going. In terms of feedback and data, it was developed not in the earliest, in the middle, so it wasn't used throughout because it evolved as everything through our own kind of process. But I know there were some clinics, some nurse case managers who used it, and I think, I don't want to say all, but we did get some, they were excited about the tool, and what it can be done is also adapted, of course, to each clinic. If they have a logo or there's some messaging they want to change on it. Yeah.
Sorry, Don, I'll just add a little bit more anecdotally when we've had training or any kind of meetings with nurse case managers, Donna and our other patient partner, Judy, have been included in some of these meetings. It's when it goes up on the screen, it's this immediate, like, oh, okay, yeah, that's great. That makes sense. And it's a really nice, tangible way to look at the project. And then also in just really recent recruitment of a clinic, the nurse case manager was using it, was giving it to some of the providers in the clinic to say, here's the study as a visual reminder, and to help explain it to them when they were introducing it to patients. So it's been a really great tool. It's had a lot of different uses.
Thank you. And that allowed me an opportunity to point out, although many people who are attending this webinar probably already know this, what Donna is talking about is the very obvious benefit of having patient-partnered research. Patients will point out to you, that's great as a researcher that you think that's wonderful. That is not working for us. We have no idea what you're doing. And one of the things, in addition to being involved in all stages of the research, one of the places where I think patient partners are really underutilized, this project's a beautiful example of how it works out, is in the recruitment phase, is in communicating the importance of why would you want to participate in this study and what does it mean and how is it going to benefit you? And then when you do collect the data, sort of the dissemination in terms of what do these results mean for all the different people. And I do want to highlight that this is part of the strategy for patient-oriented research, which means the questions should be important to patients. PIHCI and this project does patient-partnered research, which means community and patients are part of the process to keep us on track to ensure that it truly is patient-oriented. They're not completely the same thing. We would like them to be the same thing. We think it's important, and you'll always hear from our network that there's a huge and beneficial involvement of patient partners. And Donna, I was really happy to hear you say that, you know, you'd never done this before, but you jumped in. And oftentimes that lack of experience with research teams often provides important insight, because you're the first one to say, excuse me, this, what do you mean by that? It forces us as researchers who are completely in the weeds to clarify what we're doing, and almost always for a better outcome. So
I like, yeah, I just want to add a word. It's kind of a healthy friction. And if you think about friction, it's something I've been using lately to describe. I heard it on a podcast and it went, that's it, because what you get from it, it comes together as boom, is something much greater and has value.
Yeah.
Absolutely.
And I think that it's collectively our bigger learning in this project, just to accepting and letting this healthy frictions, I like the word also, and also, and trying to find solutions together. So thinking that it will be very easy at the beginning and everyone will be happy every time is probably not realistic. So yeah, and it was a very interesting, and for me, it's changed completely my way of working with patient partners, and I already have a few years of experience, but yeah, we continue to evolve, and it's very yeah, it's the interesting thing.
Yeah, it is. It's wonderful. I've been doing it for, I'm not going to tell you how long I've been doing it, because I just don't like to give away how long I've been doing research in this game. But honestly, the development of partnerships, whether they're community, patient, I even have industry partners, it has always improved the quality and rigor and impact of the research I'm engaged in. And ultimately, as researchers, that's where we're headed, right? We want to do great research, but we want our research to make a difference. And that, I think, is where your healthy friction, or what I call a course correction, is extremely helpful in ensuring that that happens. So we're almost at time, which is fantastic. I want to thank our speakers for sharing their work today. That was incredibly informative. I want to thank our attendees for their helpful comments and a rich discussion following the seminar. I know everybody is getting some serious Zoom fatigue, but thank you for joining us. This talk will be posted, and keep your eyes on our website for any future developments. Thank you, everybody, and have a lovely afternoon. And thank you also to Jamie Demore, who has been ensuring that this could happen in the midst of a lot of other work. So thank you. I look forward to seeing everybody again another time, and have a great day.